Acute Kidney Injury, Diagnosis, Causes, and Clinical Management, Part 1. Welcome to Medical Sciences Unfolded. Today we're tackling acute kidney injury, or AKI, one of the most important and high-yield clinical topics in medicine. AKI is common, dangerous, and often preventable if caught early. AKI is defined as an abrupt decline in kidney function, specifically a rise in serum creatinine of 0.3 milligrams per deciliter or more within 48 hours, or a 50% rise in creatinine within 7 days, or urine output less than 0.5 milliliters per kilogram per hour for more than 6 hours. These are the KDIGO criteria. Know them. We classify AKI into 3 categories based on where the problem originates: pre-renal, intrarenal, and post-renal. Pre-renal AKI is the most common type, accounting for about 60 to 70% of cases. The kidney itself is fine, but there's not enough blood flow reaching it. Causes include volume depletion from vomiting, diarrhea, hemorrhage, or burns, decreased cardiac output from heart failure or cardiogenic shock, and vasodilation from sepsis. The kidneys respond by trying to retain sodium and water to restore perfusion. This is why pre-renal AKI produces concentrated urine with a low fractional excretion of sodium below 1%. 2 key lab values distinguish pre-renal from other types: the BUN to creatinine ratio. In pre-renal AKI, the ratio is elevated, greater than 20 to 1, because urea is reabsorbed along with water, but creatinine is not. The urinalysis typically shows hyaline casts, which are bland and nonspecific. The treatment for pre-renal AKI is volume resuscitation, IV fluids, usually isotonic saline or lactated ringers. If you restore perfusion, creatinine should start improving within 24 to 48 hours. If it doesn't improve, suspect that intrinsic renal injury has already occurred. Intrinsic renal AKI, also called intrarenal AKI, occurs when the kidney itself is damaged. The most common cause is acute tubular necrosis, or ATN, which accounts for about 85% of intrinsic AKI cases. ATN has 2 main causes: ischemic ATN, prolonged hypoperfusion that progresses beyond pre-renal AKI, and nephrotoxic ATN, from drugs like aminoglycosides, contrast dye, amphotericin B, cisplatin, and NSAIDs, or endogenous toxins like myoglobin in rhabdomyolysis. The hallmark of ATN on urinalysis is muddy brown granular casts. These represent sloughed tubular epithelial cells. The fractional excretion of sodium in ATN is above 2% because the damaged tubules cannot reabsorb sodium properly. The BUN to creatinine ratio is typically less than 20.
Part 2. Other causes of AKI, complications, and management. Beyond ATN, other causes of intrinsic renal AKI include acute interstitial nephritis, or AIN, often caused by medications like penicillins, NSAIDs, and proton pump inhibitors. AIN classically presents with fever, rash, and eosinophilia, the triad, along with eosinophils in the urine. The fractional excretion of sodium is variable. Glomerulonephritis is another cause. The kidney's filtration units are inflamed, leading to hematuria, proteinuria, red blood cell casts in the urine, and hypertension. Common causes include IgA nephropathy, post-streptococcal GN, and lupus nephritis. Post-renal AKI is caused by urinary tract obstruction from BPH in older men, bilateral ureteral obstruction from cancer, kidney stones, or a blocked urinary catheter. It accounts for only about 5 to 10% of AKI cases, but is crucial to identify because it's often reversible. Ultrasound showing hydronephrosis confirms the diagnosis. Treatment is relieving the obstruction, Foley catheter, nephrostomy tube, or ureteral stents. Now let's talk complications. AKI can be life-threatening. The most dangerous complication is hyperkalemia. Potassium rises rapidly when the kidneys can't excrete it, causing fatal arrhythmias. Always check the ECG for peaked T waves, widened QRS, or sine wave pattern. Treatment is calcium gluconate to stabilize the cardiac membrane, followed by insulin and dextrose, sodium bicarbonate, and Kayexalate or Patiomer to remove potassium. Other complications include metabolic acidosis, the kidney can't excrete hydrogen ions, fluid overload and pulmonary edema, uremia causing encephalopathy, pericarditis, and platelet dysfunction, and hyperphosphatemia with hypocalcemia. When does a patient need dialysis? The AEIOU mnemonic, acidosis refractory to treatment, electrolyte imbalance, especially hyperkalemia, ingestion of toxins removed by dialysis, overload of fluid, and uremic symptoms. The prognosis of AKI depends heavily on the cause. Pre-renal AKI is fully reversible if treated early. ATN typically resolves over 1 to 3 weeks as tubular cells regenerate. However, AKI significantly increases the risk of developing chronic kidney disease. Up to 25% of patients with severe AKI develop CKD. Key prevention strategies: avoid nephrotoxic drugs in high-risk patients, maintain adequate hydration, use N-acetylcysteine and IV fluids before contrast procedures in patients with baseline kidney disease, and monitor renal function closely in ICU patients. To summarize, AKI is defined by rising creatinine or falling urine output. Pre-renal is most common and responds to fluids. Intrinsic AKI, especially ATN, shows muddy brown casts and FENa above 2%. Post-renal is obstruction. Relieve it. Watch for hyperkalemia, acidosis, and fluid overload. Know when to dialysize. Thank you for watching Medical Sciences Unfolded. Subscribe for more daily medical education.